I'd like to really dive into the talk because it is really a complex topic. Stroke prevention in cardiac patients is really a big deal. Our patients are really high risk, and I think for most of the gain to as a listener, you will gain a lot more if this is more interactive. So if you have any questions, please type them in the chat, and we'll be happy to address them at the end of the presentation. Again, I'm really gonna dive into it. It's really pretty much all about AFib. I'm sure you're all familiar with AFib. I'm sure you're all are aware that AFib represents the major cause of strokes in cardiovascular patients. In terms of anyone with cardioembolic phenomenon, so a non-atherosclerotic stroke, the majority, really the lion's share lies within AFib. And the way we address AFib nowadays is still rudimentary. It still needs refining. So I'm sure you're all familiar with CHADS VASC. You all use it. It's super user-friendly, and it's really a great tool to help the clinician in the clinic or in the ward to make a decision. However, CHADS VASC, even though it is a great tool, is not without problems. The C-statistics is a method to estimate the predictive value of a test. So a C-stat of 0.5 tells you that your prediction tool is only as good as a coin toss in terms of who is going to develop stroke. The C-stat for CHADS VASC is only about 0.67. And that's a relatively low C-stat. This says to the cardiology community, to the all patients, to the internal medicine community, to people who address AFib, that we need to come up with a better tool. And the problem with CHADS VASC is that you're trying to change a continuous variable into a dichotomous variable. So you want to say CHADS VASC of 1, CHADS VASC of 2, CHADS VASC of 3. And that's really not how pathology works. That's not really how patients present. So someone who is, I still remember a patient that I saw in the clinic that was 64 years old. And then I felt silly saying to that patient, well, come back in a year and then we'll start you on anticoagulation. Like, what's gonna happen? How is their risk of stroke different today compared to next year? It's not a dichotomous thing. It is a continuous variable. No matter how we try to kind of put lines in the sand. The other thing that CHADS VASC does not account for is the pathology in each variable. So someone who's diabetic but has an A1C of 5.9 still gets a point. And someone who's diabetic and has an A1C of 14 or 13 still gets 1 point. And we all know that this is not appropriate. And we all know that their risk profiles are different. The same thing, the hypertensive who's got a blood pressure of 121 is not the same as the hypertensive who's walking around with a systolic blood pressure of 190. So CHADS VASC does not account for that. One more thing that is really frequently missed is that the degree of impact for each variable is different. So someone who's got diabetes will get 1 point. Someone who's above the age of 65 will get 1 point. But if you go back and look at the predictive studies that examined CHADS VASC, the odds ratio of having strokes, if you are above the age of 64, is around 1.7, 1.8. And the odds ratio if you're diabetic is around 1.3. Again, so the impact of age is stronger than the impact of diabetes, yet they all get 1 point. The impact of age becomes significantly higher once you're above the age of 75, and that's why you get 2 points. The odds ratio to get a stroke in those large registries, if you're a woman, was 1.17. So it's a bit higher. It is statistically significant, but it is by no means similar to prior stroke or similar to peripheral arterial disease. So it is still a point, but it is not equal to diabetes by any means. There are unknown factors that we still don't know about them, because at the end of the day, AFib is extremely common. It is the most common sustained arrhythmia. So there are lots and lots of patients with AFib, and 90% of them do not have strokes. So why is it that some of the people with AFib have strokes and others don't? I think we need to get better at predicting who's going to develop strokes. And right now, our prediction models use epidemiological studies of about 100,000 people in registries. So all we know is really demographic data. And that's why our C-stat is low at 0.67. And there is plenty of research on this, be it imaging guided, like measuring the velocity in the left atrial appendage, or be it biochemical, so measuring certain hormones, certain blood markers to say those are the patients who are going to develop strokes. I think over the next 5 to 10 years, we're going to come up with much, much better models so that we know whom to target. Another thing that has been cooking for the past few years is this concept of Afib burden. So people who have a little bit of Afib, so to speak, are different than people who have lots of Afib. We know that, we still treat them the same, but we know that patients with high Afib burden represent a different group than the people who have brief episodes of atrial fibrillation. So this is a nice study that took all the patients with devices. So this is a pacemaker. This pacemaker has an atrial lead. So this is a lead that sits in the atrium. So it will be able to tell you what is the atrial rhythm, whether you're in sinus rhythm or you have some sort of an atrial tachycardia. And it categorized people to patients who have 0 to less than 5 minutes of AFib. So those are patients who have brief episodes of AFib. And that is the bulk of cardiac patients. That's a lot of patients, almost 60%. And then the other group, which is the extreme, is that people who have almost more than a day, they go more than a day with atrial fibrillation. Some of them have permanent AFib. So they've been in AFib all along and they are always in AFib. And that's 16%. And I would argue that this group is very easy to recognize. If you do a surface ECG, a 12-lead ECG, you will pick it up. If they come into the hospital for whatever reason, they will be placed on telemetry and that will be picked up. So here the chance of the clinician knowing about the disease is high. However, here the chance of the clinician knowing about the disease is extremely low unless you happen to do an ECG or they happen to be on telemetry during those 5 minutes, you're not going to know. And for those patients, their risk of stroke is not low. Their event rate is around 0.5%, which is considered higher. It's not as high as other groups, but it is considered high. And I think we need to come up with better models to target those patients, because those patients are walking around, they're not on any stroke prevention medications, yet they do have they are potentially at risk to develop stroke. Again, the money is who's going to form clots, who's going to develop clots in their left atrium and then embolize their left atriums. So on your right side here, you can see a TEE. This is a transesophageal echo where the probe is sitting in the esophagus. And then the first chamber that you're seeing is the left atrium. And in here, the mitral valve is opening very slowly, and the blood flow from the left atrium to the left ventricle is very slow. This is because of heart failure or cardiomyopathy and depressed LV systolic function. In turns, the red blood cells are not moving too fast, so they can reflect the ultrasound waves, and it appears as a smoke. So we call that a smoke sign. And what it basically means that there is stagnation of flow. So the flow from the left atrium to the left ventricle is slow, and this predisposes to strokes. This is a very common sight to see in patients with mitral stenosis or in patients with mechanical valves who have a problem with the valve itself that is restricting flow. Whenever we see this is a high risk for stroke. However, this is not practical. We cannot do TEEs on everyone to kind of estimate their flow. And if you don't have smoke sign, that doesn't mean you're not at risk of stroke. If you do have this is a high risk for stroke. On the left side here, you can see the same thing. So this is a TEE again, showing you the left atrium. And in here, this black chamber or this black appendage is the left atrial appendage. And inside it, the bright colored thing with an arrow is a thrombus in the left atrial appendage. And there has been studies in the past, in the 80s and the early 90s, that kind of examined the source of clots, and tracing the source of clots in atrial fibrillation always leads us to the left atrial appendage. So the majority of clots that are originating from the left atrium, they originate from the left atrial appendage. We've had excellent imaging in the past decade, be it 3D transesophageal echocardiography, or be it a 3D reconstruction of cardiac CTs. And this showed us that the left atrial appendage is not a single structure. It is extremely complex with different and variable shapes. Some have deep recesses, some are elongated, and that itself represents a way for us to study, well, who is going to develop strokes? Because this patient, for instance, with this left atrial appendage, the blood flow at this point might be a lot slower than, say, this patient with this configuration. So trying to image the left atrial appendage and then saying, oh yeah, this left atrial appendage is a high risk for stroke, is a potential research area where we can categorize patients into high risk and low risk. And I think in the next 5 or 10 years, something is going to happen in this arena where we say, yeah, this is a patient with AFib. However, their left atrial appendage is benign, or oh, no, this is a patient with low CHA2DS2, but their left atrial appendage is not benign, so we will place them on anticoagulation. This is not yet in clinical practice, but I think that's up and coming. Why are we interested in the left atrial appendage? Like I said, because we know that most of the clots originate from there. There's been studies on patients who have atrial fibrillation who are going for cardiac surgery. And the idea was, as the surgeon has the heart open, why not just ligate this part of the left atrium? So just ligate the left atrial appendage and exclude it. This way, blood will not flow in. And initial studies were negative and repeat studies were positive. So we still have conflicting data on this. However, the most recent well-done randomized trial showed that there is actual reduction in strokes when you do it surgically. So patients who have atrial fibrillation, they're going for cardiac surgery of be it whatever cardiac surgery, then the surgeons would ligate the left atrial appendage in order to minimize the risk of stroke in the future. I would still say it's not a standard of care. I would still say it's not yet, it is still debatable. The other idea was, well, patients who are not going for cardiac surgery, let's just go from the right femoral vein into the right atrium, cross the septum, and place this plug, which is a left atrial appendage closure device, or a Watchman device, if you've heard of the term. And the idea is that this will endothelialize and will exclude blood flow into the left atrial appendage. The clinical trials, unfortunately, did not show that there is stroke reduction. They showed that there is less risk of hemorrhagic stroke, which doesn't really fit with the whole pathology of this. So it's still debatable, and it still carries a 2B recommendation in the European Society of Cardiology guidelines for atrial fibrillation. However, if you have someone who has, let's say, significant bleeding, or they are at high risk for bleeding, and you want to do some sort of stroke prevention, and you really cannot use a NOAC or a DOAC, then that might be a potential thing to do. It is still not by any means the standard of care. I try to summarize this into the 10 rules of Afib, and I think all the cardiologists will agree on this. We know from the literature that if you screen for Afib patients, you will find Afib. The harder you look for Afib, the more patients you will find. We know this from the stroke literature. We know this from the PFO closure literature. If you look with daily ECGs, it's different than if you look on in-hospital telemetry. It's also higher when you look with a 30-day monitor. So the message here is any patients with a stroke, you really need to look hard for Afib. A single PAC on a 12-lead ECG in patients who are presenting with stroke is predictive of developing atrial fibrillation. So when you see a patient with stroke, and they even have a single PAC, that means that this patient probably has occult atrial fibrillation, and you will see it if you look hard enough. I cannot emphasize the importance of using Chad's VASC, and I don't think this needs any emphasis. Although I did critique the tool, it is really the best thing that we have. So assessing the risk with Chad's VASC is extremely important. And what to do with patients with Chad's VASC? This is a nice summary from the European Society of Cardiology, where it says when you see someone with atrial fibrillation, ask yourself, do they have a mechanical heart valve or do they have moderate to severe MS? If the answer to that is yes, then you give them warfarin or a VKA with an appropriate target ion. If they don't, then ask yourself, can I not anticoagulate them? So the standard would be, yes, they need anticoagulation. Well, can I not anticoagulate them? Sure. Who are the patients with Afib that you're not going to anticoagulate? It's the people who have a Chad's VASC score of 0, or they only have 1 point just because of being female. Again, the odds ratio of having strokes, when you have multiple risk factors, in addition to female gender, it is significant. But if you are only female, that has never been shown to actually carry a higher risk. And that does not warrant anticoagulation on itself. So in that case, there will be no antithrombotic therapy. If your Chad's VASC is higher, so 1 for males or 2 for females, then you really should consider anticoagulation. If your Chad's VASC is 2 and above for male or 3 and above for females, then there is a strong recommendation for oral anticoagulation. I want to emphasize something. It's really difficult to, as you've seen, it's very difficult to assess the risk of stroke. It's even more difficult to assess the risk of bleeding. And all the bleeding tools that we have are really not great. So I want to say that perceived high bleeding risk should not be a reason to withhold anticoagulation. It should be a reason for you to follow this patient closer, keep an eye on them, check CBC to look for any drift in the hemoglobin, educate the patient about anticoagulation and what to look for so that you can discover bleeding early. But it's not by any means a reason to withhold anticoagulation. NOACs or DOACs are the first line therapy in anticoagulation, except in mechanical valves or moderate to severe MS. And when you are dosing the NOACs, and this has been shown in the literature, and I commonly see it in clinical practice, beware of underdosing. So you see someone who's got slightly high creatinine, then you really should follow the literature or the clinical what was done in the clinical trials in order to achieve the same results. So I think underdosing is very common. We have this perceived risk of patients, in particularly for patients with chronic kidney disease or elderly or frail, where people would kind of come up with doses and just lower the dose of the NOACs. And I think you should really not do that. You should really think about that, because we know the effectiveness of those medications at the appropriate dose. When you go down with the doses, we really don't know how well are they going to behave. Tomorrow we're going to hear about different options, and I think Dr. Fadl is also addressing the issue of DOACs with patients with chronic kidney disease or renal failure, and I look forward to this talk. Patients who are currently taking warfarin, I've seen clinicians being reluctant to upgrade them, and it is really an upgrade to push patients from warfarin to DOACs or NOACs. They are superior by all means. It's been shown over and over and over. And if you have someone on warfarin and even if they're doing well, it's still you're playing Russian roulette. So even if they've had nothing for the past 5 years, I think you should upgrade them to NOAC. It doesn't matter whether you choose rate or rhythm control. So oral anticoagulation should be the standard of care regardless of your rhythm control. So after cardioversion, after you do Afib ablation, or if you have low Afib burden, it's still the standard of care to give oral anticoagulation. There are special cardiac groups, the patients with hypertrophic cardiomyopathy, the patients with amyloidosis or infiltrative cardiomyopathies. Those patients should receive anticoagulation regardless of their CHA2DS2-VASc score, because we know that those patients have slow flow in their chambers, and that predisposes them or that puts them at a higher risk category regardless of their CHA2DS2-VASc. They were also not validated in the CHA2DS2-VASc study. Exclusion of the left atrial appendage, it remains controversial. It's not considered an adequate strategy for stroke prevention. So even in my clinical practice, even when I see someone without a left atrial appendage and they've had a reason because they were at high risk of bleeding at some point, and now that reason is gone, I still place them on anticoagulation because I think exclusion of the left atrial appendage in itself is not enough. I think you've seen this plenty of times, which is the reversible AFib or the transient AFib, be it perioperative or alcohol-induced or post-MI. And I think they have different pathology, but nowadays we treat them similarly to atrial fibrillation. The last point that I want to make is really starting anticoagulation is extremely important. And this is not a regular medication. You cannot just start it and give it to the patient and they just go and collect it from the pharmacy. There needs to be a counseling that happens in the clinic, first educating the patient about the indication and why we're giving this medication and why is it important, and you're taking this to reduce your risk of stroke, and you're taking this and it is increasing your risk of harm, your risk of bleeding. However, that risk is extremely minimal compared to the benefit in terms of stroke reduction. I cannot emphasize this enough, and I think it should be part of the internal medicine graduation or OSCE for the residents. I think any internist who sees patients with atrial fibrillation should be extremely comfortable counseling patients about atrial fibrillation. This is a summary of the 10 rules on AFib, and I would like to thank you so much for allowing me the chance to give this presentation.